Hello, my name is Gabrielle Bolivas, and I will be presenting a 6-week-old female with the initials DD. This is an episodic soap. So, chief complaint: DD is a 6-week-old female infant whose mother complains has had trouble feeding since last week. Mother states infant stops breathing for about 5 seconds with feeding and is breathing funny. History of present illness. Infant was discharged home, nibbling all feedings on demand. Once home, she fed infant 3 ounces of Similac Advance every 3 hours. About a week ago, mother noticed infant breathing funny with feedings, which included not breathing for about 5 seconds during the feeding, breathing fast, and making a funny sound with breathing, and having frequent spit-ups after eating. So, review of systems. General, she's had no sudden weight loss and her growth has been normal. Her skin and limb, she reports no hemangiomas or cafe au lait spots. HEENT, her head ultrasound was done in the NICU and it was normal. She does not have a cleft lip or cleft palate. Cardiac, she does have a history of an ASD and a PFO. Respiratory, she denies a history of pneumonia, bronchiolitis, wheezing, or stridor. GI, her stools have been normal, no diarrhea, but she does report the frequent spit-ups. GU, she's voiding 8 to 10 diapers per day. Musculoskeletal, infant is moving all extremities spontaneously and no issues. Allergies, she has no known drug allergies. She's not on any meds currently. Her prior medical history includes she was born at 38 weeks gestation via C-section to a gravid 3 para 3 mom with a history of chronic hypertension. Infant was initially admitted to the NICU for respiratory distress and required nasal CPAP for 4 days. Per mom, infant was in NICU for a total of 21 days due to poor feeding and to rule out any abnormalities. She required a nasogastric tube for feeding assistance. Chromosome studies were sent and they were normal. Head ultrasound was done and it was normal. She did have an echo done and it showed an ASD and a PFO, and infant is currently following up with cardiology. Family history. Infant lives with mother and father and 2 older siblings. Father is healthy. Mother has a history of chronic hypertension. Social history. Baby lives in a 4-bedroom house with 2 bathrooms with mother, father, and 2 siblings. No one smokes or drinks in the home. So my differential diagnosis for this baby was, number 1, gastroesophageal reflux disease without esophagitis, K21.8. Number 2 was congenital hypertrophic pyloric stenosis, which is Q40.0. And number 3, overfeeding, which is P92.4. Her vital signs were: temperature was 98.3, her heart rate was 159, respirations were 30, blood pressure 70/43, and her pulse ox was 97% on room air. Her weight was 4.2 kilos, which is in the 25th percentile. Her length was 54 cms, which is in the 25th percentile. Her head circumference was 37 cms, which is the 50th percentile. So upon physical exam, she has not had any weight loss noted. She is not a failure to thrive, and she does not appear toxic. So physical exam, her skin, she was pink and warm, no cyanosis noted, no hemangiomas or cafe au lait spots noted. Her head was normal, atraumatic, no craniofacial abnormalities noted. Her eyes, she had positive red reflex bilaterally, no scleroicterus, no edema, no erythema to lids. ENT, she had no pharyngeal erythema. Her tympanic membranes were pearly gray. Her mucosa was pink. Respiratory, she did have stridor. Upon walking into the room, baby was feeding, and it was very loud. It was very noticeable. She had stridor even without feeding. And per mom, infant did not have stridor while she was in the hospital. She did not have any retractions. No tachypnea or apnea were noted. Cardio respiratory rate was normal. She did have a grade 1 murmur, and her capillary refill was less than 2 seconds. Abdomen, she had normal bowel sounds. Her abdomen was soft, non-distended, non-tender. I did not palpate any masses to the upper right quadrant or in any of the quadrants. And you could see some partially digested formula on her bib. GU, she was voiding in her diaper. She moves all extremities. Her spine was straight. She had normal reflexes, and her tone was normal. We did not have any labs done. So my official diagnosis was gastroesophageal reflux disease without esophagitis, K21.9. Treatment plan for reflux was do not overfeed the infant. We switched her from Similac Advanced to Similac Sensitive formula, and she's feeding 2 ounces of Similac Sensitive every 2 hours. Mother was asked to place infant prone or left lateral only while she was monitoring the baby. We did tell her about the risks of SIDS if baby slept prone while she was not watching the baby. Another option was to maintain an upright position for 30 minutes after the baby finished eating. We did educate mom on the fact that if baby, so although she's spitting up, she's not losing weight. She will continue to grow, and she will outgrow the reflux. We did inform mom that if infant begins to have projectile, bile stained, or bloody vomiting, to of course go to the emergency room, and mom is to return to clinic in 2 weeks to reassess reflux for her 2-month well assessment. So for my other differentials, for the pyloric stenosis, key features for that was she was a 6-week-old female, history of poor feeding. She's now presenting with stridor, slow feeding, and small frequent spit-ups as described by mom. Classic findings for pyloric stenosis, it typically occurs between 3 to 6 weeks, usually male though. Some typical features are feeding intolerance with multiple formula changes, regurgitation leading to non-bilious vomiting, failure to thrive, and weight loss. And sometimes you can palpate the olive-shaped mass in the right upper abdomen. Treatment options for pyloric stenosis would be hospital admission. This would be an emergency. She would require an ultrasound, IV fluids with electrolyte, and eventually surgery. And then for overfeeding, again, she's a 6-week-old female with a history of poor feeding. She's now presenting with stridor, eating slowly, small frequent spit-ups as per mom. And treatment plan would be to, of course, not overfeed the infant, switching her formula from Similac Advanced to Sim Sensitive, feeding her instead of every 3 hours, 3 ounces, changing it to every 2 hours and only feeding 2 ounces. And we would follow similar treatment plan to the reflex plan, which is place the infant prone or left lateral when baby is awake, and then teach parents that even though she's spitting up, she should stop once we fix her feeding pattern to every 2 hours versus every 3 hours. So in my debriefing, I did agree with the diagnosis of gastroesophageal reflux for this baby. I believe treatment guidelines were followed. Typical clinical guidelines for GERD include lifestyle changes, which include feeding changes and positional therapy. So we did include the changing the formulas and then reducing the feeding volume while increasing the frequency. Reducing the feeding volume while increasing the frequency, which was every 2 ounces every 2 hours. And then we talked to mom about keeping baby upright for 30 minutes after the feeding. Something I would have done differently would be to request a speech therapy consult to rule out any other feeding issues and laryngomalacia, which was a major concern for me because I saw the patient in the NICU prior to seeing her in clinic, and I know patient didn't have stridor before. And I also would have asked mom to place a cool air humidifier in the baby's room to see if that would also help with the stridor.